Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. I'm John Vasallo, managing editor of the series here at Elsevier, and for our 14th podcast, we will be discussing the October 2024 issue devoted to updates in head and neck cancer. As the editors write in their preface, head and neck cancer has a unique physical impact because of the social and psychological toll it exacts. In this issue, we embark on a review of new treatment and diagnostic aspects of head and neck cancer that addresses health disparities, minimally invasive techniques, and new surgical approaches. In this podcast, we will discuss some of these approaches and techniques with 4 articles from this issue of 11. Leading the discussion will be our consulting editor, Dr. Tim Pollock, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editors of the head and neck cancer issue, Dr. Sarah Rohde, associate professor and division director of head and neck oncologic surgery, and Dr. Eben Rosenthal, Barry Baker professor and chair of the Department of Otolaryngology, Head and Neck Surgery. Both are at Vanderbilt University Medical Center in Nashville, Tennessee. Welcome to all 3 of you, and over to you, Dr. Pollock.
Thanks, John. Really excited to be with Dr. Rohde and Dr. Rosenthal today to discuss this wonderful issue of surgical oncology clinics on head and neck cancers, a very important topic that I'm glad we have revisited in our journal. First of all, thank you both. Welcome, Sarah. Welcome, Eben.
Thanks for having us.
Thanks so much for having us.
You bet. So we have 4 articles that I'd like to chat with you about today amongst the compendium of articles that were included in this volume. And Dr. Rosenthal, I thought maybe we'd start off with the article that was written by Dr. Old and colleagues on the state of head and neck microvascular reconstruction. As a non-head and neck surgeon myself, it seems like over the past several decades that there's been some major advancements in head and neck microvascular reconstruction. So I'm wondering if you just start off and kind of set the stage for us about, some of the recent advances with microvascular techniques as they pertain to reconstruction in the head and neck space.
Yeah, thanks, Tim. I think the primary things are the use of, for bone reconstruction has always been a little different than soft tissue. It just is more challenging. The margin of error is a lot lower, and therefore the opportunities for improvement are there. And so probably the use of computerized and generated plates and cutting guides basically make it very, very difficult to make a mistake. And the only disadvantage of that is the cost and the possibility of a change in the resective plan that can modify that. So those are the primary thing in terms of bone reconstruction. I think the overall use of flaps has drilled down to 5 or 6 really workhorse flaps that people use, and that has simplified both the setup and the development. So I think that's and the use of the arm bone reconstruction has become more popular because it is such a limited morbidity and is more available in patients, particularly the elderly.
Yeah, I thought Dr. Old and colleagues did a nice job in this article, kind of dividing it up into preoperative considerations, intraoperative, and then postoperative considerations. One of the things that he highlighted was surgical planning around vessel-depleted necks. And I didn't know if you wanted to highlight some of the factors that surgeons need to consider in that setting.
Well, in general, when you're looking at the vessel-depleted neck, getting preoperative imaging is really important to be able to understand where there is flow. I think, considering the pedicle length in the flap that you're using, considering vein grafts as needed, those are all things that are, really pretty important in terms of managing that setting. It's very, very challenging to be able to do a graft where there simply is not a vessel, or you're exposing vessels that are difficult to get out without injuring other structures. So that pre-planning process is actually really important.
The other thing that I thought was interesting was interoperatively this idea of pharmacologic regimens to improve anastomotic success with these flaps. I didn't know, perhaps you could expound a little bit on some of the medical maneuvers that you do in the operating room or perioperatively to increase the chance of flap viability and anastomotic success.
So that's always been an area of controversy, primarily because the rate of flap failure is in the 3 to 4% range for most surgeons. And so the study of those is often complicated by many factors, both physiologic and pharmacologic. So in general, there are articles that will show a lot of different things, but I think the current so data, in other words, is very hard there are very few multi-institutional trials looking at individual agents. I think that in general, people have moved away from any kind of heavy anticoagulation in the post-op setting because of the risk of hematoma. I think that when you look at the data around things like pressors intraoperatively, those don't seem to have a big effect in most studies. The use of piperacillin and lidocaine injected directly into the adventitia of the vessels is a very common, and either in combination or alone, is a very common and successful method to prevent early vasospasm. I think so. Those are that's a little bit the areas where I would highlight where I think that that's a critical element.
And then, Evan, one thing I remember as an intern in general surgery, especially over at the VA, was my job at night to monitor the free flap and kind of report in, if you will. And one of the sections in this article was about free flap monitoring. And I was wondering if you could talk a little bit about that. Where are we at with regards to monitoring the flap in the postoperative period, whether it be with a Doppler or maybe even with some newer technology, such as the near-infrared spectroscopy that was mentioned in the article by Dr. Old.
In general, I think we have gone away from Q1 hour, Q2 hour checks. They keep the patient up, and if you do them too frequently, I feel like it's very challenging. We've also, as the resident work hours have developed, it's sort of forced us a little bit. And well, there are multiple factors. One is the need to get the patient to the floor and not to the ICU because they're not critically sick and they need to get up the next day. So if you do Q1 hours or Q2 hours, they're not going to be able to go to the floor, but there is a real need to get them out of the intensive care setting because they're better off in a setting where the nurses are going to get them out of bed and they're going to get the Foley out the next day and sort of move them through the pathway. So therefore, and there really isn't a big difference. What in general I've seen at multiple institutions is that people will move away from Q4 hour checks by the resident and stick with Q2, Q4 hour checks by the nurses. And then the best thing is if the resident checks the flap when they start call. So sometime between 6 and 8, and that's it, unless the attending asks them. And that way they know the baseline of the flap. And when that on-call resident then gets called, they have a baseline and then they can work from there. So in general, we've gone away from a heavy monitoring to more spaced out intervals in order to assess the flap, but the resident to get a baseline.
Yeah, Sarah, do you have any thoughts on that and the monitoring of the flap in the postoperative period?
No, I know Dr. Old mentioned using spectroscopy. I know that has been used by our plastic surgery colleagues more because our flaps in general, I think, tend to be smaller volume. We haven't relied on that technology as much, but certainly, that technique and other techniques that may help in the future to do monitoring that doesn't involve such a heavy load on the nursing or the resident house staff.
And then I was wondering, just the final thing that he highlighted in the article was just, future directions and possibly the use of bioresorbable reconstruction materials, and then also tissue engineering, with scaffolding materials or even, adipose-derived stem cells. So I was wondering if maybe either you could comment a little bit on, what might be emerging in the field vis-a-vis these future directions. Sarah, do you have any thoughts? And then we can see if Evan has any.
I think it's the dream. That's what I'll say. I think that we're a long way off from those things right now. The dream is to have something that you can put on your bony anastomotic sites that helps your osteosynthesis, or eventually that one day you can spare them the morbidity of a flap donor site and use an engineered material. But because our patients get radiation and a lot of adjuvant treatment, their saliva and things, we just haven't had much success with that yet in our field.
Well, the other thing is that people have tried, with the even the plates that we use to secure the bone have an extrusion rate of about 20%. And as a just indicator, which is, kind of the gold standard for non-reactive material. Even people trying to do osteogenesis distraction as a method of creating small osteotomies has been problematic just because the bone healing in the post-radiated cases. So in general, any prosthesis that we put in there, even to the point of titanium mesh over the brain for a soft tissue flap, is not universally done in the radiation setting because of the extrusion after radiation. So I think very few people are willing to put anything foreign into a oral cavity wound with the contamination associated with any surgery in the oral cavity.
Yeah, sure. That makes a lot of sense. I wanted to pivot now, maybe to talk about another article by Dr. Phillips and Dr. Topf on margin analysis. Obviously, as oncologic surgeons, one of the main principles of oncologic surgery is to try to obtain a negative surgical margin. And obviously, when you're dealing with head and neck cancers, real estate is at a premium, and you're also trying to be somewhat tissue sparing. And I'm wondering, maybe we can start off with you, Dr. Rosenthal, about, tell us a little bit about margin analysis when it comes to head and neck cancers. How do you define a negative margin? What type of width of a negative margin might you be looking for? And then even maybe you could comment just a little bit on the use of frozen section analysis in the operating room, and whether you're kind of looking at the tumor bed or do you use more of a specimen-driven approach?
So, Tim, I think there are head and neck cancer surgeons that will talk for days about this on end without any defined agreement. And probably, to answer your last question first, probably the most interesting thing is that it has consistently been shown that margins from the specimen are more predictive of survival when they're taken at a perpendicular. So that is, the specimen is removed and in centropathology, and the margin is obtained in a perpendicular fashion from that specimen. That is kind of the gold standard, which cannot always be applied for many reasons, but that's probably the best. And the reason that is most associated with survival is because a positive margin is not a margin that is at the border of your specimen. The positive margin is within 3 to 5 millimeters of that, depending on what you look at. So a cut-through margin is not a positive margin. That's just a gross cut-through. I mean, that's not really a positive margin. It's something less than 4 millimeters from the edge of the tumor. So in other words, the tumor bed, being negative at the tumor bed, simply means that you didn't have a cut-through margin. So in head and neck, and every tumor type, of course, is different, but in head and neck, that's the case. It is interesting to look at, if you look at the total number of frozen sections sent by head and neck cancer surgeons compared to almost every other field, we are off the chart. We are like 4 or 5 or 6 times more frozen sections than anybody. We send them in all these locations, and I can't really tell you why, because I don't do a lot of other cancer surgeries, and obviously the impact on the frozen section pathologist is significant. So there are many other factors, associated with obtaining a necessary margin, and if you do take a margin and you take the margin, can you relocate it properly to the specimen in the post-operative setting? So when you review a patient at tumor board and you say that the posterior lateral aspect of the tonsillar fossa is positive, it can be really hard for the communicating physicians to say, is that a real margin? Is that, like a not important margin? Is that really, where is that in terms of, radiation boost and so on? So I think that's probably the biggest factor that, and Dr. Topp that's his area of of research and excellence, and he's very interested in developing 3D models so that the treating team as a whole, not just the surgeon who happened to be there, can communicate rather than in a 3-page pathology document that is exceptionally dense and difficult to understand.
Yeah, no, I can relate to that as kind of as a liver surgeon, in a sense of, like, sometimes you do these liver resections and there may be a focal margin positive somewhere, but then trying to figure out exactly where it was and kind of recapitulate what the anatomy was to figure out exactly where it is can be challenging. That said, I know in a lot of other cancers, this idea of a positive margin, how much does it truly affect local recurrence versus overall survival, is a topic that's often discussed. So I was wondering if you could just comment, or Sarah, Dr. Ande, feel free to chime in about the importance of margins. How often do you see a local recurrence? How do you think it impacts overall survival? So from an oncologic perspective, how truly important is it?
Very, in our field, it has been shown that a positive margin leads to higher rates of local regional or poorer rates of local regional control, higher rates of recurrence, and overall survival, because surgery is the mainstay of many cancers in head and neck, in the head and neck space. We also know that when people go back to resect, like you were talking about, these focal margins, that oftentimes there is no cancer in the second specimen that you resect. And so that probably gives us extra evidence that we're not doing necessarily a great job. There's also the added standpoint of like tumor biology and looking at the worst pattern of invasion and seeing that some tumors have a very like pushing border and have a relatively better pattern of invasion. And then some of these tumors have just bad biology and are reaching behind, where you would cut. And then even when you're seeing just small cells floating out behind where you've set your margin, those patients have bad biology. And it's a second aspect of having a positive margin that affects our patients' survival.
Many patients that recur, it's unclear to what extent we're getting positive margins because of the biology and the very extensive infiltrative nature of the disease, which also lends to bad outcomes. So you have a positive margin and because you have bad biology. And I think that's what some folks would say. I also think that there is a underlying inability for us to see cancer on the deep surface as we do the resection. And it's hard when you're going through soft tissue to know, are you 1, are you 2, are you 3 or 4 millimeters from there? And so I think, as you know, Tim, there's a lot of clinical trials now and approved agents for surgical imaging where you inject an agent prior to surgery, and then you can visualize the cancer during surgery to understand where exactly the cancer is relative to your resection, and basically avoid the sampling error problem, where if you think about taking a margin, you're really taking, if you're really sampling the specimen, you're palpating it and saying, I'm going to cut here, then maybe 1 by 2 millimeter section, and then you take 5 microns of that in a couple slides. So sampling error is probably also a really big problem. And when you get one positive margin, it probably just means that you probably got a bunch. But I think there are many problems to solve, 2 of those being the communication of the positive margin, where it is, and relocating it, and 2, being able to identify as in real time where the cancer is, particularly if you have to have a cuff of normal tissue.
Yeah, and that's where I was going to go next, Evan and Sarah, was just to, and you've already touched on it, but this whole idea of like molecular margins or using real-time optical imaging in the operating room. And you've already touched on it a little bit, but, as, again, a non-ENT surgeon, where does that currently stand? You alluded to there's some clinical trials. Is this near to being prime time? Is it something that's still, currently being studied in more pilot situations? What do you see the clinical applicability of kind of this notion of molecular margins or optical imaging, either now or in the next 1 to 2 years?
Yeah, so fluorescent guided surgery, there are 3 approved agents in multiple tumor types. So Gleolan is approved in brain cancer, which is a 5-ALA, as well as in bladder cancer as an infused agent called Hexafix. The other agent is Cytalux, which is used for lung and ovarian metastasis. And in breast cancer, there's a new approved agent that was approved in March of this year for detecting margins. And I'm blanking on the name of the agent, but it's basically a way to detect a residual margin within the breast tissue cavity. So it is definitely here. It's a question of, are those technologies intuitive and helpful that pass the FDA bar, but they haven't passed the rapid adoption. I think there will be early adopters and late adopters in any technology. There are probably 10 to 15 agents in different tumor types. Some of the research I've led has worked in brain cancer, which of course is a very high impact area because of the survival and the need for maximal safe resection. George Palsides at Stanford and I collaborated to do a pancreatic trial where that's ongoing as an NIH-funded to determine whether or not you can differentiate inflammatory disease from pancreatic cancer. And that trial is in its 2nd year. And of course, we have lots of different studies in head and neck cancer here at Vanderbilt and at UAB and at Stanford. And those are looking both at the primary margin, but also, can we detect lymph nodes without taking them all out? Can we identify cancer within, small areas of metastasis within lymph nodes?
That's great. So I'd like to move on to the next article to discuss today. And Dr. Ronde, I was wondering, if you could comment on the article by Dr. Manian on the de-escalation in treatment of oropharyngeal carcinoma. It's interesting that, when I think of oropharyngeal carcinoma, I typically think of, alcohol exposure and tobacco use and treatment related to kind of surgery plus radiation and chemotherapy. But it seems over the last maybe decade or so, the HPV-related oropharyngeal carcinoma is becoming more prevalent. And there's been a move perhaps to kind of de-escalate treatment to decrease morbidity for this group of patients. So I was wondering perhaps if you could comment a little bit around, chemo radiation de-escalation strategies as they are maybe relate to HPV-related oropharyngeal cancers.
You're exactly right in that our HPV positive oropharyngeal carcinoma has now far exceeded the number of patients that we see with traditional smoking and alcohol-related oropharyngeal cancer. One of the reasons why we're so interested in de-escalation is because these patients are young and they will have a lot of time to live with the morbidity of treatment and also experience the late effects of treatment that were not as much of a concern when the patients had HPV negative oropharyngeal carcinoma and their survival rates were not as good. And we were interested in treating them as strongly as possible to save their lives. Now with our HPV patients, their survival rates are great. And so now we have these very young people who are having significant treatment-related morbidity. So there are two, main treatment paradigms for oropharyngeal cancer, and one is a non-surgical treatment, and the other involves surgery plus or minus adjuvant treatment. For non-surgical treatment, the traditional treatment has been based on our HPV negative patients and has been chemotherapy and radiation concurrently. There has been a lot of interest in, because our rates of success are so high, in dropping the dose of radiation, which has not yet panned out to be successful in our early trials. And then the second thing is replacing the cisplatin-based chemotherapy with either an immunotherapy or withholding it altogether. And the jury's still out on these. When we talk about adding surgery to these, we have a little bit more data to support that we can add surgery, and that allows us, even in more intermediate risk patients, to drop the dose down to as little as 50 gray for these patients, which really, when you're considering radiation, drops the morbidity and the level of side effects for our patients significantly.
The other thing that I thought was interesting was when surgery is utilized, traditionally it was fairly morbid, or could potentially be fairly morbid. But this article talks about some minimally invasive surgical approaches, such as transoral robotic surgery or even transoral laser microsurgery. I'm wondering if you could comment a little bit about both of those techniques as they may relate to management of this cancer.
Yeah, I think, they're both adopted by, different groups of head and neck surgeons. And really, I think it boils down to which technique you're trained in and which technique you feel comfortable with. I think the robot is gaining momentum because of the ease in being able to see what the other person is doing, having teaching screens, and really having the great visualization that you do. And that's what robotic surgery boils down to, is being able to get our tools into places that we weren't able to get our tools into, and then additionally to be able to see those areas in ways that our eyes couldn't see them. With the advent of the single port robot, which has been more designed for the oropharynx versus the other robots, which were designed for abdominal surgery, it's even allowed us to push that further towards the supraglottis and other areas where, just because of the size of the instrumentation. It's really great because in these areas, we used to be thinking kind of salvage surgery and HPV negative patients, and they were big open surgeries with free flaps, and had a lot of morbidity with respect to swallowing and speech. And now patients can have, with the appropriate tumor, have a transoral resection and no tracheostomy, and oftentimes no feeding tube, and be discharged a couple of days later with their tumor removed. So it's really exciting, and the technique is continuing to be pushed and expanded to fit our patients' needs.
Yeah, that's really helpful, Dr. Ronde. Dr. Rosenthal, before we moved on from this paper and this topic, I don't know if you had any other comments about future directions or management of oropharyngeal carcinoma.
I would just add to what Dr. Rohde said. She commented on the increased use of the robot, and that's a training that everybody doing fellowships today is coming at has, and they look for in a fellowship. As Dr. Rohde mentioned, as we increasing use of it is going to require new technologies built into that. The robotic technologies are hopefully developing rapidly, both with the optical imaging, but also with more facile use of the arms, less bulky, and some competition in that area, I think over the next 10 years is going to make that more interesting.
Well, why don't we move on to our last article then, which I think is, a very important article in this issue, and that's around the ethics and palliation among patients with head and neck surgery. So maybe we'll start off with Dr. Ronde. I'd just be curious, Sarah, about some of your perspectives on, what are some of the kind of unique ethical issues around treating patients with head and neck cancers? As I noted earlier, many of these patients traditionally had, maybe high alcohol smoking use, perhaps represented more marginalized populations or more vulnerable populations. And I'm wondering how the intersection of maybe some of those social factors with the diagnosis of a serious cancer, such as a head and neck cancer, may present some challenges around patient-physician communication and medical ethics.
Yeah, sometimes one of my mentors once told me there are no easy answers in head and neck surgery. And that's because our patients have oftentimes large advanced tumors in their mouth or throat, causing them significant symptoms. Yet sometimes the treatments in order to cure these also have significant side effects related to their ability to breathe and communicate. And that's really tough, especially for somebody who doesn't have perhaps the best social system to support them through that. I think, the palliative aspect of this is for these patients, even if you decide not to treat it with surgery, these tumors are going to grow and take away many of the same functions that we would take away with surgery. And so it's not an easy ask to just say, okay, well, I'm going to do nothing about my tumor. And that's where, increasingly targeted quad shot radiation can be an option, chemotherapy, palliative chemotherapy, or even palliative surgery just to relieve the pain and side effects from the local disease.
That's really helpful. One of the other things that Dr. Schumann brought up in the article is just this notion of operative decision making, and that perhaps an ENT surgeon, when dealing with these cancers, things may change intraoperatively. The wider resection may need to be taken, and given the anatomic location, this could have significant functional impact and sequelae. So I'm wondering if you might just talk about, how do you face that as an ENT surgeon when you're in the operating room, and what type of conversations maybe do you have with the patient beforehand, and then also how you interact intraoperatively with any of their surrogates if a decision needs to be made?
It can be very tough. Some of these patients we know well because we've been with them through their first cancer or through their chemotherapy and radiation, and are now looking at a salvage surgery. And other patients we've met once or maybe twice, looking to then do a curative intent surgery. When we do that, sometimes we encounter bad biology. And we talked about that earlier, but sometimes, you cut widely around a tumor and you still have positive margins. And speaking with the pathologist and thinking about what's the reality of those positive margins, is it something I'm going to be able to clear with surgery? When we know the patients really well, I think it's helpful because oftentimes then we can know whether they would want to go the extra mile or whether they would not, where their lines in the sand are. But there are times when we haven't had those opportunities. And I think every head and neck surgeon has had a time where you just decide to stop based either on the patient's wishes or based on communication with their surrogates. I do think that's very helpful if you have patients who have family members that have been there with them for the conversations, and you have discussed important quality of life aspects such as permanent tracheostomy, permanent feeding tube with the patient before surgery, just to know where they stand.
Yeah, that's really helpful, Dr. Rodi. I think, having that, really clear patient physician communication and also, discussions around goals of cares and making sure expectations are aligned, as you noted, is critically important. I thought maybe that we could pull Dr. Rosenthal back into this. And, Evan, some of these patients, unfortunately, you can't resect, right? You can't resect with curative intent, and you truly need to palliate them. And sometimes, as you know better than I, these can be tough situations to palliate with regards to pain control, handling of secretions, and even fistula or malodorous tumors. So I wonder, might you just comment a little bit about some of your thoughts around the palliative approaches to individuals who unfortunately aren't candidates for curative intent surgery?
I think probably the most important thing is to communicate clearly that the options are not curative. I think that's probably where, we fail, is that we should give the patients the option to die with some dignity at home, and make it clear that what we're offering is not curative. And then I think that's probably the most important statement to make, which it is surprising how often that does not occur in the setting of a surgical, a medical oncology, or radiation office, that it's such a multidisciplinary group and everybody doesn't want to say something. But I do think that the surgeon is also just as responsible as any of the other team members for making sure that the patient understands that. So once that's established, I think making sure that people know that the cure, the chemotherapy agents are often toxic. They have significant side effects, and they are only going to work in about 20% of patients at best with no good marker. And then entering clinical trials is a great thing to do. And that's probably one of their, better options. But again, that is very unlikely to work. Now, the patient and anybody who's read the Daniel Kahneman books basically understands that the patient is going to see that 5-10% chance of it working as they're going to be in that. Like, they see that as hope. And
Right.
So I think being realistic with the patient so that they have some, and the family, of course, so that they have some agency in the decision making. But of course, many patients do eventually, want to get treatment. They want that hope. So.
Yeah, well, I really want to thank you, Dr. Ronde, Dr. Rosenthal, for your time today. I think this conversation has just further highlighted for me, the challenging job that you have as ENT oncologic surgeons, and also, the challenges that our patients face who have these diseases. It's an incredibly complicated situation, not only from a medical management point of view, but operatively demands expert technical skills. And then, as alluded to in the last article, really a need for surgeons and physicians to be caring and compassionate and good communicators as these situations are incredibly complex. So, you did a wonderful job amassing a great group of authors for this issue of Surgical Oncology Clinics. And I really encourage all of our listeners to explore all the other articles in the issue, as we only had a chance to discuss 4 today. Once again, Sarah, Evan, you have my gratitude and the gratitude of the editorial staff of Surgical Oncology Clinics. Thank you so much.
Tim, thank you. It's been great.
Thanks, Tim.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to updates in head and neck cancer. The 4 articles discussed, as well as 7 others, are in the October 2024 issue, Volume 33, Number 4. This series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @SurgicalClinics, and you can find our podcast on most major audio streaming platforms, including Apple and YouTube. Visit theclinics.com for more details. Thanks for listening.